Hi, I'd like to welcome everyone today. My name is Stephanie Spencer and I'm a certified heart failure nurse, and I've been caring for heart failure patients at Arkansas Heart Hospital for the last 16 years. And if you're watching this video right now, you may be in the hospital or you may be at home, having gone home with a heart failure admission. And the reason we have this information for you is because we want to give you all the tools that you need to be able to take care of your heart failure at home and to be able to stay out of the hospital and be at home where you want to be. So anyway, without further ado, I'm going to go ahead and we'll get started here. So the first question people have when they've gotten a diagnosis of heart failure is, what does that mean? It's kind of scary sounding. Heart failure does not mean that you've had a heart attack. It doesn't mean that your heart has stopped working. It just means that your heart is not squeezing enough blood to meet your body's demands. Heart failure is a pretty common condition. A lot of people have heart failure, and a lot of people live with heart failure for many, many years. But you have to learn how to change your lifestyle with diet and different things, and you have to take your meds right and do many different things correctly in order to have a good quality of life with heart failure, and that's what the purpose of this class is to teach you about. So how do we diagnose heart failure? How did your doctor know that you had heart failure? The gold standard for diagnosing heart failure is an echocardiogram, and that's basically just an ultrasound of your heart. It's a non-invasive test where they get a picture of your heart. And what we're looking at with an echocardiogram is a number called the ejection fraction. And that is the percentage of blood that your left ventricle, and I'm going to show you on my cartoon heart over here. Right here, this is the left ventricle. That's the main pumping station of your heart, okay? So we want to find out how much blood the left ventricle squeezes out of the heart with each beat, okay? A normal amount of blood for the heart to squeeze out is about 60% for a very healthy person. No one squeezes 100% of the blood out with each beat. It's just 60% is about average, okay? Frequently, people with heart failure will have a low ejection fraction, or we call it an EF. And it's common for people with heart failure to have an ejection fraction of 20%, 25%, 30%, and they'll walk around with that for years. But it can, of course, be a lot lower. And then there's another kind of heart failure that I'm going to talk to you about also with a higher ejection fraction. So there's two kinds of heart failure. And the reason I'm telling you this is because your doctor may tell you that you have heart failure, but your ejection fraction may be 60%, and I'm going to explain that. So first, I'm going to talk about the kind of heart failure called systolic heart failure, okay? And this is what I was just telling you about, where you have a low ejection fraction of maybe 20% or 30% or even less than that. Systolic heart failure means, you can see right here, this is the left ventricle. It is a little bit enlarged, okay? This is larger than a normal heart. And what happens is that systolic heart failure is frequently caused by heart attacks. So with a heart attack, you know, you get the blood flow, the arteries on your heart get clogged up, and you have the heart attack, and what happens is that south or downstream from that artery, there was a part of your heart that didn't get any blood flow for a little bit, and that muscle, that part of the heart muscle can actually die. And so you'll get a dead spot on your heart, and so it doesn't contract well. And then over time, your heart will start to enlarge as it tries to make up for that one spot that's not beating at all. And so over time, this is what happens. You get an enlarged heart, okay? And you get not enough blood. The heart is weakened, and you get not enough blood squeezing out of that left ventricle, okay? Diastolic heart failure, now you may have been told that you have heart failure while you're in the hospital here, and yet your ejection fraction is 60%, okay? Just because you have a normal ejection fraction doesn't mean you don't have heart failure. This kind of heart failure called diastolic heart failure, and systole means squeezing, so it's a failure of the squeezing part of the heart. When we call it systolic heart failure, diastole means relaxing, so it's a failure of your heart to relax, and you can have heart failure from that. Diastolic heart failure is frequently caused by high blood pressure. And so when someone's had really high blood pressure for years and years, this left ventricle right here, the squeezing station of your heart, has to squeeze really hard against the aortic valve to eject the blood into your general circulation, because it has to really squeeze against high pressure. So it's just like when you're working out in the gym and you're lifting weights, your biceps are going to get a lot bigger, right? If your left ventricle is just squeezing against high pressure for years and years, the left ventricle, and this is called the septum, the center of the middle part of the heart, this gets really enlarged, and you'll actually get it so enlarged that the muscle kind of impinges on the cavity of the heart. So that left ventricle just doesn't have room to receive the blood, okay? It squeezes just fine. So the squeezing portion is just fine. In fact, with diastolic heart failure, you might even have a higher than normal ejection fraction of up to like 70 or 75%. And that's not necessarily meaning that that's a good thing, but it just doesn't relax to receive the blood because that cavity has gotten smaller and smaller. And so you'll develop heart failure just as bad as systolic heart failure, okay? All right, one of the most common signs that we have with heart failure, and the reason heart failure is such a big problem, is that you will get fluid buildup in your lungs. And this is what makes people run to the emergency room over and over, okay? So I always like to refer to my cartoon heart right here when we're talking about this. But say we're talking about the systolic heart failure where you have your low ejection fraction. Say you have an ejection fraction of 20%, okay? That means 20% of your blood is being ejected out, and here it's going to the aorta, okay, out to the rest of the body. But if only 20% of the blood is being ejected out, that means you've got about 80% left over. I don't know if that's really 80%, but so say we've got this much blood left over after your heart squeezes. It's really only this area right here that can pump the blood, this small area, right? And so the problem with heart failure, and why it's such a problem with people, with them going into the hospital over and over, is that very little things like going to Kentucky Fried Chicken or going to a Chinese buffet and eating lots of salt will pull lots of fluid into your bloodstream, and it raises the level of the blood right here to where it will back up into the atrium, goes through the mitral valve here, goes up into the atrium, fills up, and a lot of heart failure patients have a dilated left atrium from blood always backing up here, okay? It'll go into the left atrium, and then the next spot, it goes through these pulmonary veins right into the lungs. So it just, boom, right into your lungs. And so that's what will happen is you'll fill up with fluid in your lungs over and over until you learn to control your diet and stuff like that. So that's what we're going to be talking a lot about, but I just want you to understand how the fluid builds up into your lungs. Okay, and there's lots of other symptoms of heart failure. Textbooks will tell you that, you know, with systolic heart failure you get this, and with diastolic heart failure you get this. However, in real life, they just cross over. Lots of times with the systolic heart failure where I just showed you, and you get fluid backing up into your lungs, you will have shortness of breath. You'll find that you used to be able to walk out to the mailbox, no problem. Now you have to take 2 rest breaks to get to the mailbox. Or you may get to where you can't make it to the bathroom like you used to, and you're more short of breath. So symptoms of heart failure, we're going to have shortness of breath is one of the most common ones. And this is one of the most common things that sends people to the emergency room is the shortness of breath. Also a chronic lack of energy. When you have heart failure and you don't have enough blood coming out of your heart, so you only have half the amount of blood coming out of your heart, that's half the amount of oxygen that rides on your blood going to the rest of your body. So a lot of people with heart failure will just always be fairly fatigued, and you may need supplemental oxygen because of that. Sometimes we can correct that when we get the fluid overload corrected, and then you won't need oxygen. But as heart failure progresses, sometimes that's just kind of a part of life, and you have to learn to adjust your activities with that. Another common symptom is a cough with frothy sputum. A lot of people will come to me in the clinic for the first time, and they'll have had a cough for 3 months, and they're coughing up, and like, you know, their doctor might have told them that they had, you know, bronchitis and put them on an antibiotic or something, but it's just clear frothy stuff coming up. And once we get the fluid overload corrected and we get them on a low sodium diet and we adjust their medications, that cough will eventually go away. So that's something else to look for. Swelling of your feet and legs, probably probably a lot of us are familiar with that, but we're talking swelling to where you can like sink your finger in and leave a mark, okay? Swelling in your feet and legs is most common with diastolic heart failure, but you can also have it with systolic heart failure, okay? Difficulty sleeping at night due to breathing problems. Lots of times, like say you're leaving the hospital, we've gotten your fluid under control, we've pulled off 10 pounds, you're going back home. Then 1 week after you get home, you notice that you're used to sleeping on like 2 skinny pillows. Then all of a sudden your weight's going up a few pounds and you have to put 3 or 4 pillows under your head to be comfortable at night. Frequently that is the first symptom of fluid building back up. And it's going to build up in your lungs, and it's going to generally happen at about 2 a.m. when you've been laying flat, and then any fluid in your belly or your legs is going to work its way up to your lungs. So when you first start to notice that you're having to use more pillows under your head, you need to call your healthcare provider, or you need to call me in the heart failure clinic if you're coming to see me there. Okay? Swollen abdomen or loss of appetite. This is very common. This is more common with diastolic heart failure. But frequently patients will have fluid back up into their belly, and what happens when the fluid backs up into your belly and you also don't have enough blood flow, you don't have enough blood coming out of your heart and going to your belly, is that your gut kind of slows down. You know, you have that peristalsis where your gut is supposed to keep moving the food along. It slows down when you have heart failure, when you have fluid overload. So frequently patients will tell me, lots of times it's more elderly patients, that they've lost, their spouse will tell me that they're not eating. And that's how I'll know their heart failure is getting worse, because they lose their appetite because their belly's just not working right. And then paradoxically, sometimes people will start taking Alka-Seltzer to make them feel better. And Alka-Seltzer has 2,000 milligrams of sodium in one dose of, yeah, the plop, plop, fizz, fizz, and that just makes everything worse. So don't do Alka-Seltzer. Get your heart failure under control. Also increased urination at night when you lay down. All that urine's got to go somewhere. And then also confusion and impaired memory. You just don't have enough blood coming out of your heart to get to your brain and oxygen. So we need to do all we can to fix that. Okay, there are also, I like to explain to our patients, there's symptoms that we can control and there's symptoms that we can't control. Symptoms that we can control are severe, this is called edema, when your legs swell up like this. And this, there's really, I feel, no excuse for this. No one should be walking around like this for years and years. Usually if we can get you on a proper low sodium diet, and if we can get your medications adjusted just right, we won't get every speck of edema necessarily, but you don't have to have severe edema like this and severe shortness of breath, propping up on 4 pillows. If you've been doing that for 6 months, your heart failure is not well controlled. And we can generally turn that around. Sometimes things that we can't fix with heart failure, because there's no pill that you can take, there's no surgery you can do that's just going to make your heart failure go away. It's kind of like diabetes and the fact that it's a chronic condition that we have to just learn to manage over the years. So some things we can't control is, like I was talking about, fatigue, just because even though we can get the fluid under control and you are perfectly fluid balanced, you still don't have enough blood squeezing out of your heart as much as your body would like. So you may just always have a degree of fatigue that we just have to learn to limit activities. You may get to where you just have a chronic need for oxygen, and you do not get addicted to oxygen. If you need oxygen, you need to wear it, because then you will be able to do the stuff you need to do. Also, low blood pressure. Frequently when you have the systolic type of heart failure, your heart's just not squeezing hard enough, so your blood pressure will simply be low. And you may be a little bit fatigued from that. And that's just another thing we have to learn to just space out your activities with that. Okay, so now I'm going to talk about treatments for heart failure. And these are, I like to explain this part, this is what your doctors do for you. And I'm talking about medications and devices for your heart failure. And then later on, we're going to talk about what you can do, what only you can do to help your heart failure. And that's even more important than what the doctors do. But first, we're going to talk about the medications. There are several medications that we use to treat systolic heart failure, and these are medications that block bad neurohormones. We've come to find over the years that heart failure isn't just a pump problem, it's what we call a neurohormonal problem, because when you get heart failure, you get these bad things circulating in your body that tend to make your heart want to get bigger and bigger. And so we try to give you medications that block those neurohormones so that your heart won't get bigger and bigger, and it might even tighten up a little bit, okay? Those medications are useful for systolic heart failure. For diastolic heart failure, the main treatment that we have for diastolic heart failure is to simply control your blood pressure, okay? People with high blood pressure are going to get worsened diastolic heart failure, so we just got to get that under control. And then we're going to talk about devices, which when I say devices, basically these mean like fancy pacemakers. And that's another thing that we use we're going to go into. Okay, so the first medication that is the cornerstone for heart failure treatment is beta blockers. And many of you are probably on beta blockers. Two of the most common ones that are recommended for heart failure are Coreg or carvedilol, or toprol or metoprolol succinate. That's the generic term. Beta blockers, if we get the dose high enough, they can actually strengthen the heart's pumping ability by 10 to 15%, increase your ejection fraction. So say you started out, frequently a patient will come in off the street, we find out you have heart failure. This is new onset, you had no idea, and you've got an ejection fraction of 25%, okay? The first thing we're going to do is to get you ramped up on medications that help your heart failure, mainly the beta blockers. So if you've never taken a beta blocker before and now you're starting Coreg or toprol for the first time, we're going to hope that over the first 3 months of starting this med that we might get your ejection fraction up to 35%. That'd be great, because once you're above 35%, then you don't need any of these fancy devices. You don't need any surgeries to have these devices put in. So we want to really ramp those up. We know that beta blockers, they also reduce deaths by 31 to 35%, people that take the beta blockers compared to people that don't take beta blockers. So it's really important to take as much as you can. Side effects of beta blockers are you can, when you're first starting the beta blocker or increasing the dose, you can have increased fatigue and sometimes a little bit of increased fluid retention. So we really want to only increase doses of beta blockers when you are what we call dry, when you're not overloaded with fluid. Beta blockers will lower your blood pressure a little bit, and so sometimes we're limited as to how much we can ramp the dose up by your blood pressure. But we want to get you on as high a dose as possible so we can get the effects of as much effects of the beta blocker as we can. So, okay, and another thing I want to say is don't think that we're giving you the beta blocker for your blood pressure. A lot of people with heart failure have low blood pressure, and then we put you on a beta blocker, and you go home and you pick it up from the pharmacy, and the tag that comes on the med from the pharmacy says this is used to treat blood pressure. And you're saying, well, my blood pressure is 95/60. I don't need to take this. No, we're giving it to you for your heart failure. We know you have low blood pressure. We just want to see if you can tolerate this amount of beta blocker so that you can get the beneficial effects of increasing your ejection fraction, okay? Also, beta blockers will lower your heart rate. If you don't have a pacemaker and you have a heart rate of 60 or lower, this may limit how much beta blocker we can give you. But a lot of people with heart failure have pacemakers, and once you have a pacemaker, it'll never let your heart go too low, and we can just ramp up those beta blockers. Okay, the next class of medication that we're going to give heart failure patients are called ACE inhibitors, okay? And these are meds that end in pril. So there's a whole bunch, one of the most common ones is lisinopril, or Zestril, or Prinavil, Captopril, Acupril, lots of different things. ACE inhibitors can lower death rates in heart failure hospitalizations by 25 to 45%. So it's really important. People that are on the optimal doses of ACEs and beta blockers will simply live longer than heart failure patients that aren't on the good doses of these meds. ACE inhibitor side effects, a lot of people will get a cough with ACE inhibitors. They say about 10% of patients get a cough, but in my experience, it seems like it's more than that. If you get a cough, we can switch you to a different kind of a med called an angiotensin receptor blocker, which ends in sartan, like losartan, valsartan. And these other sartan meds are just as good as ACE inhibitors for people that can't tolerate an ACE inhibitor because of a cough. Another side effect of ACE inhibitors, just like with the beta blockers, is lowered blood pressure, okay? Also, we can have worsening kidney function, meaning you can have an elevated creatinine. Sometimes people with really bad kidneys, we're just not going to be able to give an ACE inhibitor to because it's too hard on your kidneys. Also an elevated potassium level. And so basically all heart failure patients are going to need to have blood work checked on a regular basis, but we just check this with blood work and make sure that you're doing okay. Aldosterone antagonists are the third form of evidence-based meds that we want all heart failure patients to be on if they can handle it. And the most common kind of aldosterone antagonist is aldactone or spironolactone. That's probably what's going to say on your bottle. That's the generic form, is spironolactone. Spironolactone is kind of a mild diuretic, but really what it does is it blocks these bad neurohormones just like ACE inhibitors and beta blockers do. And it really has shown to have a lot of good effects with heart failure patients. They did a trial, and you know, beta blockers and ACE inhibitors are generally the first two that everyone gets. Then they did a trial back in, I think it was in the 90s, and they found out that when you add spironolactone on top of ACE inhibitors and beta blockers, that they reduced deaths by 30% and hospitalizations by 37%. This is huge. And so spironolactone usage really skyrocketed after that trial came out because it's so helpful for heart failure patients. However, with spironolactone or with aldosterone antagonists, there's again some things we have to look for. They will cause, they can cause elevated potassium levels and elevated kidney function levels, so you simply have to monitor blood work. What I like to do is everyone that has been started on spironolactone, I want to check a potassium and a creatinine level 1 week after initiation of spironolactone. And also whenever I increase spironolactone doses, I want to see blood work and make sure that you're doing okay. So this is another reason why you can't leave the hospital and just see your doctor a year later, okay? Another side effect of spironolactone is a kind of an odd one called gynecomastia, and that means enlarged breasts. And this will happen frequently in men. And spironolactone costs about $4 a month. Eplerenone is another kind of aldosterone antagonist that costs $4 a day. If you start to have these gynecomastia symptoms, we need to stop spironolactone and we can switch you to eplerenone, but it's more expensive. But just know if that happens, that is most likely due to spironolactone. Now, this is the last med we're going to talk about, and this is the newest med for heart failure treatment. This was recommended by the American Heart Association and American College of Cardiology in 2009, and it's called Bidil. And it's a combination of these two meds called isosorbide and hydralazine. But anyway, it was really exciting. They found out through clinical trials that Bidil had an amazing effect on African Americans that have heart failure. Not so much the same effect with other ethnic backgrounds like Caucasians or whatever on their heart failure. But with African Americans, we found that when we add Bidil on top of, so they're already on beta blockers, already on ACE inhibitors, if we add Bidil, then we get a 43% reduction in all-cause mortality or death rates and a 33% reduction in the rate of first hospitalization, already on top of standard therapy. So this is amazingly exciting. The problem is that Bidil does lower blood pressure again, and lots of times we're working with not a whole lot of blood pressure, but if I have, on my African American patients, if I've got enough blood pressure, once I get them on the ACE and the beta blocker, then we're going to try for some Bidil and try to get that dose as high as possible. So now we're going to talk about those previous meds that I talked about are what we call evidence-based meds. And all those first meds, those are basically like vitamins for your heart, okay? So that means they're good for your heart. We want you to be on the highest dose possible, okay? Now I'm going to talk to you about diuretics or water pills, all right? Pretty much everyone that has heart failure is going to have to take some kind of a water pill. And water pills are kind of a necessary evil. You have to have them generally, but we want you to be on the lowest dose possible. I mean, we want you to control your fluid overload by not eating too much salt so you don't have to take lots of diuretics, because diuretics have side effects that we just assume you didn't have. So the 3 most common diuretics are Lasix, the generic name is furosemide, and these are loop diuretics. They're just the strongest kind of diuretic there is. So Lasix or furosemide, Bumex or bumetanide, Demodex or torsemide. Those are our basic 3 main diuretics that we use. And they're really effective. They'll make you go to the bathroom, because the way that we're going to compensate for the fact that, remember over here, we just can't squeeze enough blood out, and so you'll tend to have blood backing up and fluid backing up. We're just going to pull that fluid out of your bloodstream with the diuretics, and that'll help balance things out, okay? Side effects of diuretics is usually when you urinate out urine, you're also urinating out potassium. And potassium is vital for all bodily functions, for your heart, for your muscles, for everything. If you have too low of a potassium level, your heart can have really bad rhythms. And if you have a defibrillator, you can get shocked from having a low potassium level, okay? So frequently, patients taking these strong diuretics have to take a potassium supplement with it in order to keep up with that. So here we're going to talk about thiazide diuretics. And this is another class. Hydrochlorothiazide is a common one, and Zeroxylin or metolazone is another kind of diuretic. These are, the hydrochlorothiazide, sometimes people will get that for high blood pressure. Your doctor will give it to you. And sometimes people with just kind of some mild heart failure might be taking a hydrochlorothiazide pill. But once it gets bad and you're kind of in the hospital all the time, we're probably going to advance you to a loop diuretic. Sometimes when the loop diuretics don't quite work good enough, sometimes we have to try something else that I like to call a booster pill, and that's what we call Zeroxylin or metolazone. And that works on a different part of the nephron. I'm going to go ahead and show you a slide here. This is what we call the nephron. This is like the unit of urine filtration. You have like 30 million of them in your kidneys, I don't know. But this is the part that's called the loop of Henle, but this is where the loop diuretics work, okay? But a lot of people that take diuretics, they've been on Lasix for 10 years, you know, years and years. So they've been sucking this fluid through the loop for years and years and years. And what happens is over time, this area and this area, these parts of the distal and proximal tubules there, they get really swollen because we've just been pulling solutes through these structures for years and years, and they get swollen almost shut, okay? And then we're giving you a diuretic that works down here, but nothing can make it through up here. Well, that metolazone, or Zeroxylin is the brand name, that I call the booster pill, and a lot of my patients in here, I have them on booster pills or take it as needed for fluid overload. So what that booster pill does is it dilates this part of the nephron here. So the booster pill, we're going to take 30 minutes before your diuretic, like the Lasix or the Bumex or the torsemide, okay? And the reason is, so in that 30 minutes, it's going to work to dilate open this part of the nephron, okay, that has previously been kind of clamped shut. And once we dilate that open and then we take the loop diuretic, well, boy, all that urine can just whoosh, come right on out and into the bladder, okay, into the kidneys. So that's why, but you may be prescribed metolazone when you leave here, and we frequently call it the booster pill, but I want you to know you need to take it 30 minutes before your morning loop diuretic, which is Lasix or Bumex or torsemide, okay? Meds that are not recommended with heart failure. These frequently will get patients into trouble. There's this class that we call NSAIDs, or non-steroidal anti-inflammatory drugs. These are over-the-counter drugs: Motrin, ibuprofen, naproxen, Aleve, things like that. anything that is not Tylenol, or Tylenol is also called acetaminophen. Anything that's not Tylenol or aspirin, that's a pain reliever in this class, will cause problems for heart failure patients. What it does is it makes the diuretics not work right. It blunts the effects of diuretics in the kidneys. And so, and another class is like these COX-2 inhibitors called, you see commercials for them, Celebrex, Vioxx, or Mobic. These meds will also make your diuretics not work well. And I've had patients come to me and they're up 7 pounds and they can't breathe and they have no idea why. They've been doing their diet just right. And I'll ask them if they've had any med changes. Yeah, they started on Mobic last week. That's why you're retaining fluid. So generally for a heart failure patient, and again, always check with your doctor about any medication that you take, but generally heart failure patients can take Tylenol with no problems, and aspirin won't cause these problems either, but check with your doctor about any kind of pain medicine. Another med that causes problems for heart failure patients is Lyrica. Lyrica will cause a lot of fluid overload and fluid retention. That's something that's frequently taken for what we call neuropathy, or like the nerve pain that you get with diabetes in your feet. Another thing is Actose and Avandia are diabetic pills. These are not recommended for people with heart failure. I've had patients come to me 35 pounds up full of fluid because they got started on Actose. So this doesn't mean that people without heart failure can't take these pills. These pills work great on pain, but if you have heart failure, not recommended for you. And for diabetes, these are not going to be good for you with heart failure. So now we're going to talk about devices. So the first part of what doctors can do for you is medications. The second part is devices. And by devices, I generally mean, well, I'm going to explain it, but you'll think of them as like fancy pacemakers, okay? The first one that we're going to talk about is an implanted cardioverter defibrillator, okay? Or it's called an ICD, all right? Heart failure patients are at increased risk, patients with systolic heart failure. And if you have an ejection fraction of below 30%, you are at high risk of having a very bad heart rhythm called ventricular fibrillation or rapid ventricular tachycardia, that the only way to treat that rhythm is with a shock. And, you know, like you see on ER or these TV shows where they haul you in and do the defibrillator thing. Well, if you have a rhythm like that, you have to be shocked within about 10 seconds or you will not be doing well. So what we do is we'll go ahead and implant a defibrillator for patients whose ejection fractions are staying below 30% with maximal medical therapy. So again, if you come in off the street and we find out that you have an ejection fraction of 20%, okay, and this is the first time we found out that you have heart failure, the first thing we're going to do is ramp you up on those medications, on the beta blockers, on the ACE inhibitors, and then frequently what we'll do is we will put this thing called a life vest on you because we know that you're at high risk for having these fatal arrhythmias. So there's this thing called a life vest, which is an external defibrillator, and you just wear it. It's just got some straps here and some little sensors here and in the back, okay? So you'll leave the heart hospital with this life vest frequently. And what it'll do is it just senses externally if you are having a bad rhythm, and it will shock you if it senses that. But the standard of care is that you don't get a defibrillator for 3 months after onset of diagnosis, an implantable defibrillator, because we want to see if the medications are going to help you. So the beta blocker might increase your ejection fraction from 20% to 35%. And so then we're going to do another echo in 3 months after your new onset heart failure, and you may be 35%, and then we don't even need to do this implanted defibrillator, okay? So that's why we do it that way. So when the heart is having ventricular fibrillation, the video doesn't want to work there, but it just quivers, okay? So it's basically at a complete standstill. And the only cure for that is a shock. And so this device, this is your defibrillator here. It's just a little, it's like a pacemaker. It's a little bit bigger than a pacemaker, but it's just going to be this thing under your skin here. It's continually sensing your heart rhythm. And if it ever senses a bad rhythm like that, it's going to deliver a shock, and then your heart goes back to the sinus rhythm. And that's great, because then you're still with us. Okay, so that fixes an electrical problem, all right? So the next thing I'm going to talk about, the next kind of device is called a cardiac, well, it's called, the big name is cardiac resynchronization therapy, and that's really hard to say, so we call it a BiV pacer. It's a lot simpler, meaning a biventricular pacer, okay? And you may hear your doctor refer to this as the Cadillac of pacemakers. That's why I have the Cadillac thing here. But this is for people that, for systolic heart failure, again, when you have that big heart, frequently the ventricles, the left ventricle and the right ventricle, ideally we want them to squeeze together, okay, and eject the blood. But as your heart gets enlarged, they tend to just get out of sync, and so your heart will end up going like this, which isn't very efficient. We want it to do this, right? So what that does is it helps a mechanical pump problem, okay? So you should be able to see here, this poor guy's heart, he's got that systolic heart failure, and you can see the left side beats and then the right side, left, right. See that, how that kicks in afterwards? And that's just not an efficient way for your heart to beat. Okay, so now I'm going to show you, this is the out of sync heart, you can see here, and it's going to go left and then right, and then compare that. See, this has the BiV pacer. There's a pacing wire on both sides of the ventricle, and those are beating right together. Go ahead and run it one more time just so they can see it good. But yeah, some of you in the hospital might have been told that you need to have, you might have a defibrillator already, and your doctor's saying, I want to do a BiV upgrade, or put a third wire in. And lots of times we can just run the third wire in. That's going to go over on this side and pace both sides of the heart together. So what this does, this BiV pacer, it helps a mechanical problem, okay, as opposed to an electrical problem. And so this is actually always treating your heart. When you get a defibrillator put in, the defibrillator is more like a safety net. You know, it will save your life if you need it. But it's not doing anything to treat your heart when it's not shocking you, okay? A BiV pacer, or that third lead that the doctor may have told you about, is pretty much always going to be making both sides of your heart beat a lot more efficiently. So frequently patients will get a BiV upgrade, or they'll just get a BiV pacer implanted for the first time, and they'll really start doing a lot better. They'll be able to walk further and breathe better, and it really makes a big difference. So this is a pretty exciting thing to do. We've been doing these for about, oh, I'd say 12, 13 years now. So, okay, so now I'm going to talk about what we call advanced therapies for heart failure, okay? And this is after your heart has gotten to where we're looking at ejection fractions, 20%, 15%, 10%, when a patient, you've probably had heart failure for many years, and your heart is starting to get weaker and weaker. A heart transplant is the final option for heart failure that doesn't respond to conventional treatment. It's the only actual, I guess, cure for heart failure. But a heart transplant you shouldn't think of as, you know, just no problems at all. It's exchanging the problems of heart failure for the maintenance required for a heart transplant. If you have a heart transplant, you have to take lifelong immunosuppressant medication so you don't reject your heart, your donor heart. Heart transplants can extend your life for up to 10 to 20 years. And anyone that's getting a heart transplant needs to not have many other problems wrong with them. They need to only have a bad heart, okay? And there's an extensive workup involved with a heart transplant. Heart transplants in Arkansas are done at Baptist. There's usually only one transplant center per metropolitan area. So we have Baptist does transplants, and then there's also a transplant center in Memphis and in St. Louis. So Baptist criteria, and that's where we mainly refer patients for transplants, they have an age cutoff of 70 years old. After age 70, you're probably not going to get a heart anyway. And you must be nicotine free for 6 months. That is verified by urine tests. And like I said, you must have few other major medical issues. And then all my patients that are over 70 are like, well, that's not fair. So let me tell you about the next thing we have. The latest device that we have for advanced heart failure therapy, and it's kind of exciting, it's called a left ventricular assist device. And this is it's a pump that's planted internally with an external power source, basically. But this is an artificial pump that we're able to implant, and in 2010, it was approved for what we call destination therapy. This used to be something that only patients that were in the ICU waiting for a heart transplant would get. But now, since 2010, patients with just, end-stage heart failure can get this left ventricular assist device, and they can just have that for the rest of their lives then. And it's really exciting. You have to have, there's several criteria too, but the criteria is not nearly as stringent as with a transplant. And you can certainly be over 70 and you can get a left ventricular assist device. You might have heard Dick Cheney had an external left ventricular assist device. And that's probably our biggest celebrity that's ever had one. But that's what it looks like. The company that makes it is called THORATEC. And it's, this part here is inside you. So it is open heart surgery, and you get this pump put in. It's a continuous pump. It's not pulsatile. So once you get this in, you don't have a pulse anymore. But so the blood is just routed. All you need, it doesn't matter how big your left ventricle is, we just need a cavity for that blood to fall into. And so the blood's going to come into the left ventricle. It just needs to have gravity to bring it down here, and this is your pump. And it's kind of interesting. It's made with rubies and stuff, and they've got engineers that are always working to upgrade it. The next version of it is going to be magnetized, so there's magnets that always keep it going. But anyway, and it shoots the blood right up here above the aortic valve into the aorta. So you just need a cavity, and the machine does the rest, and it's just going to pump the blood. And it's really exciting because patients that have bad heart failure, they really do improve with this left ventricular assist device. A lot of them that have been disabled, they can just go back to work. They get down to what we call a functional class level 1, which is doing really pretty well. These are external battery packs that the patient has to wear because it's such a big thing. It's a pump. It's not like a pacemaker that we can run off of a battery that's implanted. The batteries have to be changed frequently, so you have to wear the batteries externally, and the power line exits through your abdomen right here. So you have a little line that you have to keep dressed, okay? But I'll tell you, I've had patients that I've referred over there, and they were just not doing well, couldn't walk very far, and they'll come back and visit me, and they look like $1 million. Just more animated, they're walking far, they're forcing fluids, which will be shocking to you after we finish the second part of our thing here. But anyway, this is just a little animation of what the left ventricular assist device does. So there it is going in. You can see how big that heart is. That's not an efficient heart. It's so large. Well, guess what? It shrinks back down a little bit. And you'll see here too, the liver, a white liver means it's not getting enough blood flow, and it's enlarged, it's engorged with fluid. Now the liver's shrinking back down, the kidneys are pinking up again, your kidney function gets a lot better once you have good blood flow. I even know of a young girl that had really bad heart failure. She was very young, and she got this left ventricular assist device put in, and she had it for about maybe like 8 months, and her heart actually recovered, and they were able to just take that back out, and she has normal function of her heart right now. And so there's lots of exciting things that you can do with these left ventricular assist devices now. But this is just to give you a broad overview. So you understand, like, we start out with treatment with heart failure, we're just taking pills. And then if your heart failure advances and the squeezing pump, the squeezing function is not improving enough with the pills and it's still dropping down, well, then we can do these devices and we can put that biventricular pacer in and give you some, you know, it's not terribly invasive, and we can give you a little extra kick out of your heart, okay? And then if you get to the point where your heart is really bad, and this is usually after many, many years with heart failure, then these options, these advanced options are available, and that left ventricular assist device is being implanted in quite a few patients these days. So yeah, that's just to give you an idea of all the things that we can do here. So, okay, now we're going to talk about, we're almost to our break. We're going to talk about hospitalizations. Generally, heart failure that is well managed, chronic heart failure, should really be an outpatient disease. We shouldn't have people run into the hospital over and over. However, we know statistically that when someone's in the hospital with a heart failure exacerbation or a heart failure flare-up, they have about a 25% chance of being right back in the hospital again in 30 days because heart failure is really hard to manage, okay? But if we can teach you everything we need to know, which is why I'm having everyone watch this video, then you have a lot better chance of staying out of the hospital. If you're going into the hospital with fluid overload, that's not good for you. And we do know that over time, when you have a new onset of heart failure, you know, you kind of have this trajectory, and when you're first diagnosed with your heart failure and we get you tuned up and stuff, you'll tend to kind of do okay and you'll plateau, but then over time you'll have that first heart failure hospitalization, okay? If we don't get you tuned up, and maybe you'll need a biventricular pacer or something like that at that point, and if you don't learn to really do a low sodium diet for real, then you'll start having more and more hospitalizations. And once you start having more than 4 hospitalizations in a year, you really only have an average life expectancy of 6 months. So it's really important that we don't let your heart failure just get bad, you know, exacerbate and fill up with fluid over and over and over, because your prognosis is not good when that happens. So we really want to aggressively manage your heart failure outpatient, and we want you to do what you need to do with your diet so that you don't keep filling up with fluid, okay? The prognosis for heart failure, after 5 years from time of diagnosis, less than 50% of heart failure patients are still with us, okay? After 10 years from diagnosis, only 25% of heart failure patients are still with us. So this is a pretty high death rate. This is the kind of death rate that cancers have. And people tend to not take heart failure as seriously as like a cancer diagnosis, because every time we pull that fluid off of you, lots of times patients think that they're cured, but they're not cured from their heart failure. The heart is still being stressed every time you fill up with fluid like that and go in the hospital. So, and this is another reason why, if you want to be in this 10-year group and not in the 5-year group, that's another reason we need to be very aggressive with those medications that I talked to you about. The ACE inhibitors and the beta blockers, the aldosterone, the Bidil, those are the things that are going to make you live longer. And we want you to be down here and even further out if possible, okay? Now we're going to talk about advanced healthcare directives, and in your packets here, I have some information about that, and I also have an advanced directive for you, or a living will. Living wills are something that are, I like to tell people, they're really for your family more so than for you. And no one wants to talk about what's going to happen if you're no longer able to make decisions for yourself, or if something unforeseen were to happen, okay? But preparing for medical emergencies like this is just the same as preparing your estate or preparing, you know, for your passing, for your heirs and stuff like that. So if you can plan ahead, especially for heart failure patients, this can really help your family in times of crisis. The way a living will works is that it says at the top there that this only takes effect if you are determined to be in a terminal condition by your physician, okay? So even though you write out a living will, it doesn't mean from that point forward you'll never have CPR or anything like that. It just means that when your physician has determined that there's no meaningful chance for you to, that you're going to recover, that's when they'll enact whatever your wishes are there, okay? And on that form you can put down, you know, do you want to decline CPR or a ventilator or whatever, okay? But it is really helpful to your patient or to your children to know that you've discussed this just once and that they know what your wishes are, because generally it's going to be someone else that's having to make that decision, and they'll feel so much better if they feel that they're doing what you wanted them to do. All right, so this is the second part of our heart failure video, and what we're talking about now is what you can do to improve your heart failure symptoms. Kind of the first part was what the medical people do, and I would say the part about what you can do to improve your heart failure symptoms is, I would say, about 60% of the battle. I have lots of patients that come to me in the heart failure clinic and they're taking all the right pills and they have all the right fancy pacemakers in, but they are still full of fluid and they can't walk to the mailbox and they don't have a very good quality of life. And it's because they're not doing the part that they need to do, which we're going to talk about coming up here, which is diet and stuff. So the first thing we're going to talk about is you need to weigh yourself every day for the rest of your life if you have heart failure, okay? First thing in the morning, empty your bladder and get on that scale, okay? And do not weigh yourself again at 6 p.m. and then be alarmed that you gained 4 pounds. Everyone gains weight throughout the day, so we're only going to compare morning weights to morning weights, okay? In general, what we're looking for is weight gain. Like you told me here, a patient here was just in the hospital and he found out he was up 10 pounds, or they pulled 10 pounds of fluid off. You can pull 10 pounds of fluid off in a day, you can gain 10 pounds of fluid in a day. Not so with fat. So if your weight goes up 2 to 3 pounds in a day or 3 to 5 pounds in a week, that's when you need to call your healthcare provider. Remember earlier when we were talking about the symptoms of heart failure? Those of you that are in the hospital, you're going to have this sheet of paper here. This is what I call the heart failure stoplight, okay? And the first line here, this is the green zone, and that means you're weighing every day, your weight has been stable, you're breathing okay, things are going all right. The yellow zone means our weight is starting to go up along with some heart failure symptoms. So 2 to 3 pounds in a day, or maybe up to 5 pounds in a week. Okay, maybe you might gain 10 pounds in 3 days, all right? And then you may also have more shortness of breath, propping up on more pillows at night, coughing more. That means you need to get a hold, if you're coming to the heart failure clinic, you need to call me, or you need to call your family doctor or your cardiologist, whoever you are able to get a hold of fastest. But when you find out that you're getting into trouble and you're in the yellow zone, we can generally turn that around on an outpatient basis. If you think you can walk this off and just ignore it and it's going to get better, you are rapidly going to advance to the red zone where you find that you are up 10 to 15 pounds, or this is what happens if you don't ever weigh, okay? You're just going to wake up one night, be unable to breathe, you'll come into the ER, we'll compare your weight to your previous weight, and you might be up 20 pounds, okay? You're unable to breathe, chest pressure, you have to go to the ER at that point. But if you can learn to weigh every day and call us when you start to get into problems, we can prevent you from going to the ER, okay? Okay, so number one of things we're never going to forget to do is daily weights, all right? Number two is a fluid restriction. And y'all will see, when you're in the heart hospital, we don't give you the big old jugs to keep next to your bed because we have a lot of people with heart failure. We use these little mugs here, okay? And this goes up to, I usually go by ounces because people go by ounces, but this goes up to 10 ounces here. So when you have heart failure and you've been in the hospital with a heart failure flare-up, you generally need to limit your fluid intake. And the reason is that everything that you drink doesn't go straight to your bladder and into the toilet. Everything you drink goes into your stomach and it gets absorbed into your bloodstream, and then it has to be pumped by your heart, right? Remember how we talked over here about the things that make you fill up, make your heart fill up with blood, and then the blood just goes right into your lungs, okay? All that extra fluid. Too much fluid is one of the things that will make this level go all the way to the top to where your heart can't pump anymore, okay? So generally we want to keep, if you've had a heart failure admission, we want to keep your fluid intake to no more than 64 ounces a day, which is a half a gallon, okay? or 2,000 cc's. And you know, sometimes I'll have patients that like, you know, I have like a younger man or different people, but they may drink a gallon a day. You're just used to drinking a whole lot. And this is anything that's liquid at room temperature, okay? If they're drinking, you know, like a gallon a day, sometimes that's the only thing we need to do is have them limit their fluid intake, and then they're able to walk through the grocery store again. Even though they were on all the right meds and had all the right devices, they never knew to limit their fluid or never did limit their fluid, okay? So that's one thing you can do to make yourself feel a lot better. And to be clear, if you don't have heart failure, you don't need to limit your fluid intake, okay? But if you do, this is why you're watching this video. You don't want to end up like this guy here in the hospital. This is what happens when you eat way too much salt and have way too much fluid, and then you end up going into the hospital. This says this poor guy's got all these signs. This is a real patient. And in fact, there were signs all over on the inside of the room too. This is a 1,200 cc fluid restriction, which is like 30 something ounces a day. We're not letting this guy have any fluid because he's totally full of fluid. Do not give the patients fluid. No free water. Someone's got a messed up sodium level too. So anyway, you don't want to be that guy. Another thing you can do to improve your heart failure is quit smoking, okay? Smoking, I mean, we all know smoking has lots of problems, but heart failure patients that quit smoking will have a 30% lower death rate than patients that do smoke. You have all the same benefits of taking like an ACE inhibitor. So say you've got not great kidneys and we can't put you on an ACE inhibitor, but you smoke. If you quit smoking, you'll have just as much mortality benefit or chance of living longer as if you were able to take an ACE inhibitor, okay? And the benefits of quitting smoking for heart failure patients will kick in within 1 year. To decrease your cancer risk, you have to be quitting smoking for longer than that. So there's lots of good reasons to quit smoking. If you're ready to quit smoking, please talk to your doctor about that. Exercise is really good for heart failure patients. Back in the 50s, if you had heart failure, your doctor would give you Lasix, because that's the only thing we had back then, and tell you to go to bed and arrange your affairs. Well, we don't do that anymore. You can see we've got a whole lot of more stuff we can do for patients. But generally, we want patients with heart failure to get out and do as much as they can. Check with your doctor first and make sure it's okay to exercise. You may need to start out really slow, like just 5 minutes a couple times a day. I like to encourage my patients, you know, here in Arkansas, it's 110 degrees in Arkansas, I mean in August. So sometimes if you can get a treadmill too, that's a good thing to just be able to walk, or you can walk, you know, at Walmart or at the mall. But start slowly and build up, maybe 20, 30 minutes a day. And when I'm talking exercise, I mean walking, gardening, things like that. We're not talking like running on the track necessarily. So just do what you enjoy. Gardening, biking, water aerobics are really good too. Heart failure patients, I want you to avoid extremes of temperature, and I usually don't, you don't have to harp on anyone in Arkansas to avoid low temperatures. We naturally do that. But when it gets hot outside, I always have this issue with patients that want to go out and weed eat. And when it gets really hot, and you know, down here it's so humid, and you go outside and you start to sweat. I want you to understand this. When you start to sweat, the way you sweat is that your capillaries, the tiny blood vessels, are bringing fluid to the top of your skin so you don't get overheated, right? So you can have evaporative cooling. But when that happens, all your capillaries have to dilate to bring that fluid up, okay? So if all over your body, every single capillary is dilating and you have a 20% ejection fraction, what do you think is going to happen to your blood pressure? It's going to go down, okay, because everything's opening up, all right? And so what will happen is people will go out to weed eat and they start to sweat, and the next thing they know, they're laying on the ground, okay? So that's generally why a heart failure patient, I just don't want you to be out to the point where you are sweating hard. You're going to get dizzy and fall over, okay? So just try to do your activity in the summer, like early in the morning or late in the evening, and avoid those extremes of temp. Okay, so now here's our big thing, the low sodium diet. If you can only do one thing, do this, okay? But a low sodium diet is the most important part of managing heart failure. And I'll tell you, in my heart failure clinic, this is our low sodium guru right here. This is Dawn, our assistant. And this is what Dawn does for a living, is get people to do a low sodium diet and help them do so. And it makes all the difference in the world. There's people that will tell you they couldn't go shopping until they change their diet. It makes a huge difference. Okay, so anyway, sodium in general, what's the big deal? The problem with sodium is that it attracts water. It pulls water into our bloodstream, okay? And that's a problem when you've only got a small area to pump, okay? So if we eat a lot of sodium, it pulls into our bloodstream, it's gonna raise the fluid level in your left ventricle, which already has too much blood backing up in it, okay? And it'll back it up all the way into the lungs. Sodium is a necessary part of life. Sodium is in every living thing. There's sodium in all plants, there's sodium in all animals. So pretty much everything we eat has some sodium in it. I don't want you to be on a 0 milligram sodium diet. I want you to be on a 2,000 milligram sodium diet, okay? Generally, the way I try to explain it to people is that God made all of us, and God made plants and animals, right? And the amount of sodium that God intended us to have is the amount that is in fresh fruits and vegetables and non-processed meat. It didn't occur to God that we were going to like add all this sodium and get the majority of our food from fast food restaurants, because our bodies weren't intended for that. So yeah, that's the deal with that. So yeah, a lot of Americans, they say, the literature says eat an average of 3,500 to 5,000 milligrams of sodium a day. I think it's a lot higher than that. If you're eating fast food and you're eating biscuits and gravy, you may be getting 7,000, 8,000, 10,000 milligrams of sodium a day. And if you have Alka-Seltzer, you're in a world of hurt. So heart failure patients generally need to limit their sodium. American Heart Association would like you to limit it to 1,500 milligrams of sodium. I try to keep you to 2,000 milligrams. Everyone would do well to be on a 2,000 milligram sodium diet, whether you have heart failure or not. Okay, that just means you're going to be eating less processed food. And it's going to be good for your blood pressure too, even if you don't have heart failure. Okay, so for you family members out there that are dreading this low sodium diet that your spouse has to go on, just remember, it's good for everyone. It's good for your children to be on a low sodium diet. Okay, and so when I go to talk to patients in the hospital, which I do all the time, and I try to explain to them before they go home how important it is to limit their sodium, they say, oh, don't worry, I have been on a low sodium diet for 20 years. I don't sprinkle salt on my food. Okay, well that's great, but as you can see here, you only get about 6% of your sodium intake from table salt, from the salt shaker, okay? About 3/4 of our sodium intake is already in the food. It's in processed food, okay? Naturally occurring sodium, it's only 12%, okay? So we eat a lot of processed food in this country. We are in a hurry, we don't have time to cook stuff from scratch, and that's where we get the majority of it. So don't think that just not sprinkling salt is good enough. You're gonna have to actually change what you choose to eat, okay? So the next natural question is, well, I can have a salt substitute, right? Salt substitutes are made of potassium chloride. Salt is sodium chloride, okay? So the answer to that is you need to ask your doctor, and again, you need to have blood work. Everyone is different. Sometimes I have patients that have a low potassium level all the time, even though they're taking tons of potassium. And these patients, I'll say, you can have all the salt substitutes you want. But then I have some patients that have a high potassium level and they're not taking any potassium, and I'm trying everything I can to get their potassium level down to a normal range. And you absolutely cannot have a salt substitute in that situation. So you just need to ask your doctor and know what your potassium level is before you take a salt substitute. It can also interact, if you're one of these people that thinks you don't need to have blood work for a year, don't take a salt substitute, because it can interact with your medications, spironolactone, ACE inhibitors, and cause a high potassium level. Okay, so now we're just going to talk about the low sodium diet. And for those of you that have the handout here, this is the part where you cannot look at your handout, because I'm going to ask you to guess how much sodium is in this food, and you can't look down and cheat, okay? So, come on, there we go. Okay, so when we tell patients that they need to do a low sodium diet, lots of times what we think of as a healthy alternative is not necessarily low sodium. So this looks pretty healthy, right? It's a turkey sandwich with lettuce and tomatoes, and what could be healthier than that, right? Let's just go to Subway and get sandwiches all the time, right? So how much sodium do you think is in this turkey sandwich? Don't look down. Anyone? Anyone want to hazard a guess? 500? Okay. 600? Yes. 5%. Okay, that's a good point. I'm going to bring this up. The answer is, survey says, 863 milligrams, okay? That's in 3 ounces of turkey, okay? And one slice is generally an ounce, 1, 2, 3 ounces. This isn't including the bread, okay? Or the mayonnaise. So Dawn, you can turn Dawn around and ask her what any sodium, how much is that whole sandwich, Dawn?
Probably around 1,300.
Yeah, with the bread and everything, okay? So we have to learn to do some things differently. And okay, so we were talking about percentage. Here's the percent, and this is percent of recommended daily allowance. Well, there you go, boom, 1/3 of what you need for the day right there, okay? But for patients that are trying to track their sodium content and we want to keep it to 2,000 milligrams a day, okay? Don't look at the percentage. It's just going to confuse you and it's not useful, so for our purposes. So just keep track of the milligrams, okay? So we're going to do a whole bunch of this. A better choice would be to get a turkey breast. You can get like a, just a regular turkey breast and roast it. And that's not going to be injected with sodium, because think of the turkey breast at the deli. It's perfectly round and wrapped in plastic. And think of what a live turkey looks like, okay? There's been a few things done to it. So if you can get a fresh turkey breast, that's going to have way lower sodium, okay? Anything in the deli counter, even the turkey, is going to be very high in sodium. So, and pretend these chips are not on there, but anyway, or they're low, so there is such thing as chips. There's a such thing as chips with no salt, so that's what that is. Yeah, so that's what we're going to aim for. Okay, chicken noodle soup. Who loves chicken noodle soup? Yes, we all love chicken noodle soup. How many? Don't look down. Don't look down. How many milligrams? How much? 950 in one can. 1280. Anyone else want to weigh in? Well, let's say the whole can. How much is in the whole can? And Dawn, of course, is not allowed to answer. 1780 per can, okay? Now, granted, it's condensed and you're supposed to water it down and make 2 servings, but what if you had that whole can? That's your whole day's allowance. So, yeah, Campbell's chicken noodle soup or any kind of chicken noodle soup is not going to be a good option for you in the can, okay? Now, however, you can do this thing called making soup from scratch. And don't even have to be scratch, because you can buy this boxed chicken stock. It doesn't have to be this brand, but this brand, Kitchen Basics, has an unsalted chicken stock that comes in like a quart. It's a quart, isn't it? Yeah, and there may be other brands, but what you always have to do is look at the sodium content. You got to look at this label on the back, okay? When you look at the back of that Campbell's chicken soup label, it's going to say like 860 milligrams per serving. And it's going to tell you that that can is 2 servings, okay, which is going to equal 1,700, all right? When you look at the back of this, 150 milligrams per serving, okay, and a serving is a cup, all right? So you can get this the chicken stock, and you can make chicken noodle soup. You can put noodles and carrots, and you can get some, you know, boneless, skinless chicken and boil it and shred it and put that in there. So you can make your own soup, you know, using this kind of stuff. It's a lot better alternative than getting the canned, okay? Now, for all the people that tell me they are on a low sodium diet and don't sprinkle salt on their food, are probably not thinking about their chicken and rice casserole dressing or recipe, right? And all our fancy bring to church casseroles that always call for cream of chicken soup and cream of mushroom soup. So how much sodium do you think is in, let's just say, cream of chicken soup? Any guess? I see a cheater here that looked.
Why did
Which one's 800? Okay.
well,
All right.
All the Campbell's is terrible.
Well, it's the canned. It's not the
The other ones have less than
right. So 2,175 milligrams in the cream of chicken soup. 1375 in the cream of mushroom. Yeah. So yeah, these are not good options for you for making a nice healthy casserole. Okay. So now here's my favorite thing. So you're going to be healthy. You're getting your Subway sandwiches and you got your salads. And what is everyone's favorite dressing to put on salad? Ranch. Right. Okay. So I mean, shoot, that looks healthy, right? It's got fields and vegetables. It's got to be healthy, right? How much sodium? And do you know what a serving of ranch dressing is? It's 2 tablespoons, which is like a little tiny thing, which if you get a big salad, that's like dipping your fork tines in, and then and if you have control over it, you're probably just pouring it on, right? So let me ask you this. How many of you think, what would be better, low-fat ranch or regular ranch if you have heart failure? What would be your best alternative? Who says low-fat is best? Raise your hand. Wow, these are smart people. Who says regular? Okay, wow, you guys are very smart. All right, let's see what it says. In regular, there's 290 milligrams of sodium in just 2 tablespoons, which is not very much. But say you're going to be super healthy and do the low fat. It's 440 milligrams of sodium, okay? All right, so what could we do instead of ranch dressing? Oil and vinegar. Vinegar has 0 milligrams of sodium, and you can use what I do when I'm making a salad. I'll get a bowl and just eyeball. I use olive oil. Pour some olive oil in the bottom and then just eyeball it. Then pour 1/3 vinegar, 1 part vinegar to 3 parts olive oil, or whatever you want to use, whatever kind of vinegar you want. And you can put some fresh cracked pepper in, whisk it up, dump your lettuce on top, and then just toss it, and you only get 1 bowl dirty. So, but anyway, and then when the Bradley County tomatoes come out and everyone comes into the ER because they're sprinkling salt on their tomatoes, okay? Try this oil and vinegar, okay? And you can even get, the Italians call this a caprese salad, but you can get fresh basil, and if you can get fresh mozzarella, it's low sodium, tastes delicious, okay? Try that instead of salt, all right? Another option that we have for like chili, one of our greatest hits, and for those of you watching this at home, you will have been given this in the hospital, and this is our home care instructions, and we have a lot of recipes in the back, and I have a recipe for low sodium chili here too. So these recipes I refer to are in this booklet. But you can get, this is no salt added, this Williams chili seasoning, so you can just add that to your meat or your deer meat or whatever when you're making chili, and get low sodium canned tomatoes, and you've got a pretty decent chili recipe there.
Stephanie, I'm kind of new at this, and I've been noticing that you have 2 options. You have reduced sodium and no salt added, and then you have your original sitting right next to it, and there's so much difference between no salt added and low sodium. The low sodium will really get you in trouble quick.
Okay, so the question is, basically, is reduced sodium a good idea? And Dawn can answer that question.
Well, what no sodium added means is that the only thing that's in there is what's naturally in there. Low sodium is they didn't add as much to it as they add to the normal without any restrictions on it.
But you can still get, like, you can have reduced sodium Campbell's chicken noodle soup. It's reduced down to 680 milligrams per serving. That's still too much, right? So reduced just means it's relatively less. So what I always recommend to people is always look at that label. Don't go by any healthy green labels on the front. Always look at the nutrition label on the back, this one, and read how many milligrams of sodium is it per serving. And then we're going to talk about plotting this all out on your daily food diary. But you just have to count, is that going to fit into 2,000 milligrams in a day? Okay? All right, so this is our nemesis here. Y'all are probably familiar with the 2-piece chicken meal from Kentucky Fried Chicken. How much sodium do you think is in that? Anyone? It's a lot. Okay. Oops, let me show you. How about 2660? You have overshot the entire day in this one plate of food. So this is why fast food is not a good idea. You can make fried chicken from scratch at home if you have the energy. You know, you can bread the chicken in flour and pepper and garlic powder and fry it in canola oil or whatever, but when it comes through a drive-through window or a fast food restaurant, it is just, the meat is saturated in salt, the breading is salty. Dawn, tell them the KFC story.
We had a gentleman who came to see us, and I explained all that to him, and on his way home, whether to prove to himself or to me that it wasn't true, he stopped and got a 2-piece meal at KFC. By 6 o'clock the next morning, he was back in the emergency room, up 8 pounds, and could not breathe.
Yeah, so we're not just saying like, you know, this will be good for your blood pressure. If you won't be able to breathe if you eat this much sodium and you have heart failure, okay? Here's another thing that people try to do while they're trying to be healthy with their healthy Subway sandwiches and their salads with ranch dressing. This is only a salad in an academic sense. It just has shredded iceberg lettuce. But we get lots of sodium from things like flour tortillas, okay? Anything that is like a quick rise is gonna have baking soda or baking powder in it, which is lots of sodium. And this healthy taco salad has got 1650 milligrams of sodium. So in general, at a fast food restaurant, the only thing you can get is the water or a salad with oil and vinegar on it, okay? So just to keep in mind, fresh is low sodium. You can eat a truckload of fresh fruits and vegetables and you're gonna be fine. You know, like I said before, everything has sodium in it, but celery is gonna have like 2 milligrams of sodium in it. All this fresh stuff has very low amounts of sodium. So you don't even have to worry about it really if you're eating fresh foods. It's once it's been processed or put in a can or frozen and breaded and put in a box that you really have to worry about the sodium content. So it's best to just learn to cook different things. Here's another good one. This is a grilled chicken sandwich, and when people think that they're going to be healthy, they're going to go get the grilled chicken sandwich, right? And there's also a such thing as crispy fried chicken sandwiches, which I know we're all aware of. What do you think has less sodium, the grilled chicken sandwich or the fried chicken sandwich? Who says
Grill.
has less? Okay, grilled is less. Anyone think that fried has less? No. Okay, well, let me show you. The grilled chicken sandwich has 950 milligrams of sodium, all right? The fried chicken sandwich, 710 milligrams of sodium. Kind of shocking. And this doesn't mean, so the moral of the story is just eat fried chicken sandwiches. But it's still too much. But the reason is you can fry stuff, and Americans will eat anything if it's deep fried, okay? But if it's grilled, they inject it with all sorts of like savory spices, but what that really means is salt, because you have to make it taste zippy, right? But a hamburger, which is naturally very fatty, you don't have to add a lot of stuff to make it flavorful because the fat makes it flavorful, right? So when you get the supposed healthy grilled chicken sandwich, it's going to be full. All fast food chicken is generally about 1,000 milligrams of sodium in that breast of chicken, okay? So that's not a healthy alternative, all right? Just for the record. This is no good. 1360, lots of times I'll have patients that come into the heart failure clinic and they stopped and got their sausage egg biscuit on the way in, and sure enough, they're going to need some IV Lasix. A better alternative, and what I'm trying to explain with that slide is that biscuits are another quick rise bread. that has baking powder in it. Okay, baking powder is full of sodium. And in your booklet here, in this booklet, I have a recipe for low sodium biscuits using featherweight baking powder that you can get at health food stores. Okay, and it has 0 milligrams of sodium in it. Yes, ma'am.
Turkey bacon or turkey sausage be
That is a very good question. Is turkey bacon or turkey sausage a good alternative to regular sausage? Dawn?
No, it's not, because a lot of it goes back to the no fat. So to compensate, they've made it saltier. A lot of times the turkey processed products are higher in sodium because of that.
Yeah.
They're just lower in fat, not lower in sodium.
Yeah, it's the same thing as like hamburgers and grilled chicken sandwiches. Technically, I mean, hamburgers have less sodium than a grilled chicken sandwich does. Not to say that you should just eat hamburgers, but anyway. So a better choice to your sausage egg biscuit from McDonald's is this toast is going to be always lower in sodium because bread is risen with yeast. Okay, and there's always some salt. You don't have to put salt in bread, but most all bread has salt, but it's not going to be as much as a biscuit. Okay, so if you have toast instead of biscuits and some fresh fruit and an egg, there you go. All right, so that's way lower in sodium. Other high sodium culprits, soy sauce. Think of soy sauce as black salt. It is very high in sodium. Even the low sodium soy sauce is astronomical. You just can't do soy sauce. MSG is monosodium glutamate. That's what is in a lot of Chinese food. Okay, like I said, baking soda and baking powder. Your banana bread, zucchini bread, your biscuits, donuts, things that are not salty tasting have a lot of sodium in it because of the baking powder, and a heart failure patient has to watch that. So it's not just sausage and potato chips we're saying that you have to watch things like quick rise breads also, okay? Fizzy tablets like Alka-Seltzer, like we talked about before, 2,000 milligrams in an Alka-Seltzer. If your heart failure is getting worse and you got no appetite and you feel sick to your stomach and then you start taking Alka-Seltzer, you might as well just start driving to the ER because you are going to be full of fluid. Breads, wraps, and biscuits. Well, the wraps, you know, like tortillas. Flour tortillas have like maybe like 180 milligrams of sodium. A corn tortilla has about 11 milligrams of sodium in it. So a corn tortilla is a way better option than a flour tortilla because a corn tortilla, we don't have to rise it, okay? Cornbread is really high, just like all your quick breads, okay? Bouillon cubes, you know, you make your roast and you put a beef bouillon cube in. That is 1,000 milligrams of sodium in those shiny little bouillon cubes, okay?
What about using sea salt?
That is a very good question. Okay, sea salt. Lots of times people will think, aha, I can do sea salt because it's healthy. Wendy's says it is. The difference between sea salt and regular salt is that, like say per 1,000 milligrams of sodium, and sea salt has trace minerals in it, so maybe of the 1,000 milligrams of sodium we're talking about, maybe like 100 milligrams of that in sea salt is going to be trace minerals, okay? Trace minerals are great, but not if you have to get 900 milligrams of sodium per half a teaspoon to get them. So sea salt is too high sodium for a heart failure patient. It's still just all sodium basically, except for little trace minerals. Okay, so no sea salt. Tips to add flavor. If you can add fresh lemon or lime juice. Lots of times, you know, like at home I'll make up like fried pork chops, and in Germany they have these Wiener Schnitzel things and they put lemon on it and it's delicious. We put lemon on our fish, why can't we put lemon on other things? So try just squirting some lemon on that. When you're making like a big vat of chili, okay, instead of putting a whole bunch of salt in, you can put like a tablespoon of vinegar in, like apple cider vinegar or white wine vinegar, white vinegar, and it'll add a lot of flavor to your big vat of stew or whatever you're making without the salt. And my philosophy on that is when you've got, you know, like a big Dutch oven full of chili or something, it takes a lot of salt. You have to almost add like a tablespoon of salt to even get any salty flavor out of it, right? So you're better off to just put 0 salt in, and you can put your vinegar in or whatever. But then when you're serving the chili, for example, if you put just like a little bit of cheddar cheese over the top, you know, cheddar cheese does have sodium in it, but you only need a little bit to give you some flavor, okay? And then you could put maybe some lime juice or fresh cilantro or something, and it's really flavorful. But to get the amount, to make it taste salty, you have to put a whole bunch of salt into a big, huge bowl of chili or a big, huge pot of chili. And give your taste buds time to adjust. It takes a few weeks, and people think they're dying at first, but your taste buds will eventually adjust to a low sodium diet, and then you won't crave the salt anymore. And when you maybe are in a situation where you have to eat a big salty thing, you won't even like it. The salt will start to taste kind of metallic and chemically, and it won't taste good to you anymore, because you'll get to where you can taste the flavors of the food and herbs and things like that. So, and you can always cook with fresh herbs. You can cook with anything but salt. Pepper, garlic. Make sure you use garlic powder and not garlic salt. Same thing with like onion powder, not onion salt. There are all sorts of things like Mrs. Dash has no salt. You can use that all day long. Cavender's is a Greek seasoning that there is a no salt version of Cavender's. But there's lots of things in the store. So just look on the back of your low sodium spices, you look at the back and make sure it says 0 milligrams of sodium. They have to tell you how much sodium is in it, okay? But yeah, our general philosophy is that if you can eat the right food, that is going to do more for you than taking all the pills in the world and having all the surgeries. Of course, you still have to take the pills I tell you to, but food will improve the quality of your life. Eating the right kind of food will make a huge difference for you when you have heart failure. I've got, these are some recommended low sodium cookbooks. This gentleman is a heart failure patient himself, and in fact Don has a blurb on the back of his latest book. There's a lot of really good recipes here. I recommend that you just invest in a low sodium cookbook. Another good resource for people with heart failure is this book by Dr. Silver called Success with Heart Failure. In fact, I called him and asked him if I could use the title of his book for my class, and he said he didn't own that phrase, so yes. But this is written for patients, and it's everything you could want to know about your heart failure just explained to you, and I'm sure you can get that off of Amazon. Very, very good book. And then we've got there's a lot of internet resources, and in this book that you got in the hospital, or that y'all have here, in the back, there's a page with all these internet resources. One of the best ones here is dietfacts.com. When you're going out to eat, or you know you've got an event that you're going to, this has the sodium contents in a bunch of restaurants. So you can look ahead and figure out what can you order so that you don't end up in the emergency room that night. Healthyheartmarket.com is another really good resource, and I have those little cards on the table there that have this website too. But this is a place you can order a whole bunch of low sodium items, like they have low sodium ketchup, low sodium barbecue sauce. They have that featherweight low sodium or no sodium baking powder. So yeah, you can order this stuff there, and it makes a big difference. So just as a recap, the things that you can do that are even more important than what the doctors can do as far as if you want to feel better with your heart failure: 2,000 milligram sodium diet, 64 ounces of fluid, no more than 64 ounces of fluid a day. However, I want you to drink at least 40 ounces a day. Don't try to be an overachiever and drink 2 ounces a day. That's no good, okay? Also with the sodium, for my patients that are taking diuretics, I don't want you to have any less than 1,000 milligrams of sodium a day, okay? Because the diuretics pull off sodium too, and you could get sick. So no less than 1,000 milligrams, but no more than 2,000 milligrams a day. Weigh every day for the rest of your life, quit smoking and exercise. And yeah, our whole philosophy here is that the more you know, the better you will do. Knowledge is power. Yes, ma'am?
I don't use salt, I use the no salt.
Right, yeah, no salt is, and because I know exactly what your potassium level is because you come to our clinic, yeah, that's just fine. So as long as you ask your physician or whoever's taking care of you, then we can let you know if you can have the no salt. So that's great. Yep. And yeah, and there's another thing that we tell our patients, you can know all day long, but you still got to do it. So don't tell us you're just going to try. Actually do this stuff. It will make a huge difference. You'll be able to live a full life. You'll be able to do all sorts of things. You just have to know what you need to do and actually do it. And so that concludes our heart failure class, and I appreciate you all for participating, and for those of you at home, I hope that you learned some valuable tools, and I wish you luck with your heart failure. Thank you.